हमेशा खुश रहो बेटियाँ. A very good morning to you all. Myself, JVN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine in Faculty of Homeopathic Science at Jayoti Vidyapeeth Women's University, Jaipur. In today's lecture, we are going to discuss about osteoarthritis. We are going to discuss everything about osteoarthritis. Osteoarthritis is basically a disease of the locomotor system. In today's lecture, we are going to discuss about what is osteoarthritis, what is the etiology, that is, what is the cause of osteoarthritis, what are the various clinical features of osteoarthritis, how to investigate the case of osteoarthritis, and what is the management. So, in short, we are going to discuss completely about osteoarthritis today. This is a very important disease because we get a lot of patients of osteoarthritis in day-to-day practice. So let us start with the osteoarthritis. First of all, the introduction part. Osteoarthritis is one of the most common form of arthritis. There are two terms basically in the locomotor system. One is arthralgia and the other is arthritis. Arthralgia represent only pain without any kind of swelling of the joint, whereas in arthritis, the pain is associated with inflammation and swelling. It is a disorder that is characterized by progressive joint failure. There is progressive joint failure or inability of a joint to function, in which all the structures of the joints have undergone pathological change. So all the joints have undergone pathological changes. It is a condition of the synovial joint. This is basically what a condition of the synovial joint that is characterized by following features. We have focal loss of articular hyaline cartilage. There is proliferation of a new bone, remodeling of the joint contour. So there is focal loss of the articular hyaline cartilage, there is proliferation of a new bone and remodeling of the joint contour. This is basically the pathophysiology of osteoarthritis. In the first figure, you can see the normal joint, the normal knee joint, which has blood vessels. We have meniscus of the knee and we have articular cartilage. This is the normal structure, the first one. In the second one, there is the symptoms of mild osteoarthritis, in which we have the cartilaginous breakdown. The cartilage is breaking down a little bit. We have the narrowing of the joint space. The joint space is getting narrowed. The third figure is there is greater joint space narrowing. There you can see the bone spurs, that is osteophytes. There is loss of articular cartilages. So we have severe osteoarthritis. So we have three figures. Number one, the normal articular cartilage. The second one is the mild osteoarthritis. And the third one is the severe osteoarthritis. Osteoarthritis belongs to the chronic non-inflammatory arthritis. Basically, what is there? There is chronic non-inflammatory arthritis with the involvement of the distal interphalangeal joint and carpometacarpal joint, hip joint and the knee joint. So most commonly larger joints are involved in case of osteoarthritis. The osteoarthritis targets only small and larger joints of the body, but more commonly larger joints of the body are involved. The knee and the hip are the principal large joints involved. So the knee joint and the hip joint are principally the main joint that are involved. Both are larger joints. Now we come to the epidemiology. In epidemiology, we have the prevalence. It is more uncommon in adults under the age of 40 years. So we can say that osteoarthritis is more common usually in the old age people. There is a high prevalence. The high prevalence of this disease is over the age of 60 years. So greater than 60 years, more people are having osteoarthritis. It is more common in women than in men. That means the disease is more common in women in comparison to the men. 80% of the people have radiographic evidence. So we have radiographic evidence means we have positive signs of the bony changes or the joint changes in the x-rays or the radiographs. And only 25 to 30% of the people are symptomatic. So we can say out of 100% patients who are coming to us with the radiographic changes, only 25 to 30% of the patients will have symptoms. Now you can see the changes. The figure 1 is having, these are the x-rays of the knee joint. In the first x-ray you can see the normal joint which will represented by the joint spaces. First one is having normal joint spaces, and in the second one we have narrowed joint spaces. You can see the narrowing of the joint spaces, and also you will have bony spurs. You can elicit or you can see the bony spur in the joints. Then we have you can see the bony spurs or the degeneration of the bones, especially in case of osteoarthritis. Now, what are the predisposing factors? There are a lot of factors that are responsible for the development of osteoarthritis. There are certain predisposing factors. The predisposing factors includes constitutional susceptibility, that is the constitutional tendency of an individual to develop osteoarthritis. There is heredity. There are certain hereditary factors. It is gender associated. As we all know, this is osteoarthritis is more common in females in comparison to the males. There is also association of the hormonal status. Obesity is having direct relation of osteoarthritis because more the weight of the individual, the more pressure will be there on the knee joint, and due to which the patient will be more obese, will be prone to develop osteoarthritis. There will be high bone mineral density. If the bone mineral density is higher, then it can predispose to the development of osteoarthritis. Aging is another important factor. As the age progresses, we all know the older people are more prone for developing osteoarthritis. The other factors includes trauma, joint spaces, alignment. That is, after any injury, there are more chances for development of osteoarthritis. The joint shape, if there is any deformity in the joint shape, then there is more tendency for developing osteoarthritis. Alignment of the joint is important. Usage, the more you use a particular joint, the more are the chances for development of the osteoarthritis. Occupational, there are certain occupations or jobs which a particular patient is doing, which can lead to the development of osteoarthritis, and various recreational activities that can lead to the development of osteoarthritis. Then we have mechanical factors. There are various, these are the basically mechanical factors. So predisposing factors constitutes of the mechanical factors and the constitutional susceptibility. So this was all about the predisposing factors for development of the osteoarthritis. Now, what is the pathology involved in development of osteoarthritis? Through this slide, we are going to understand the pathology of osteoarthritis. You can see the normal knee joint in this particular picture. The pathology that is involved includes remodeling of the bone contour. There will be remodeling of the bone contour. There will be fibrillation and focal loss of hyaline cartilage. There will be marginal osteophyte or the ossification of the new fibrocartilage. There will also be subchondral sclerosis. There will be secondary bursitis, capsular thickening. The capsule, the synovial capsule will be thickened. There will be osteochondral body, synovial hyperplasia, and secondary ethistopathy. These are the various changes that are occurring in the particular joint that can lead to the development of osteoarthritis. So this is basically the pathology of osteoarthritis. Remodeling of the bone contour, fibrillation and focal loss of the hyaline cartilage, marginal osteophyte, that is ossification of a new fibrocartilage, subchondral sclerosis, secondary bursitis, capsular thickening, osteochondral body, and synovial hypoplasia and secondary ethistopathy. Now, what is the etiology and pathogenesis of osteoarthritis? There are numerous pathways that lead to osteoarthritis, but the initial step is often joint injury in the settling of a failure of protective mechanism. So there are numerous pathways that can lead to osteoarthritis, but the initial step is often joint injury. So first of all, the thing that is happening in development of osteoarthritis is basically a joint injury in the setting of failure of protective mechanism. So after injury, if the protective mechanism is not set, then it can lead to the development of osteoarthritis. There are various factors like the mechanical factors, metabolic factors, genetic factors, constitutional factors, and damages of a synovial joint and trigger the need for a repair. The process involves production of a new tissue and remodeling of a joint shape. So there is production of a new tissue and remodeling of the joint shape. Pathogenesis. The pathogenesis is usually slow but efficient process compensates for the insults, resulting in an anatomically altered but pain-free functioning joint. That is known as compensated osteoarthritis. So basically, development of osteoarthritis is a slow and efficient process which compensates for the insults, resulting in anatomically altered but pain-free functioning of the joint. There is compensated osteoarthritis. Insult is even as an event which causes damage to the tissues or the organs. So what is an insult basically? This is an event that causes damage to the tissues and the organs. After overwhelming insults of a defective repair response, the system fails, resulting in progressive tissue damage. So due to the failure of the system, there is progressive tissue damage, and it is more frequently associated with symptoms and presentations as joint failure or osteoarthritis. Now, what are the different changes in osteoarthritis? Changes in osteoarthritis can occur at various levels. The changes can occur at the level of cartilage, bone, and other changes. So we have changes in the cartilage, we have changes in the bone, and we have changes in the other places, bones, cartilage, and other changes. Now, what are the various cartilaginous changes that are seen in case of osteoarthritis? So in the cartilage, there are a lot of changes that are occurring in case of osteoarthritis. The earliest change in osteoarthritis begins in the cartilage. So the earliest change start to begin in the cartilage in case of osteoarthritis. There is enzymatic degradation that takes place in the two major components of the cartilage. Type 2 collagen that provides tensile strength. Aggregans that provides hydrated gel-like structure that endows the cartilage with load-bearing properties. Osteoarthritis cartilage is characterized by gradual depletion of the aggregans, unfulfilling of the collagen matrix, and loss of type 2 collagen, which leads to increased vulnerability. There is fissuring of the cartilage. So the cartilage is basically fissured. The cartilage surface is getting fissured and it leading to the development of deep vertical clefts. So there are development of the deep vertical clefts, localized chondrocyte death, and decreased cartilage thickness. So there is deep vertical cleft, localized chondrocyte death, and decreased cartilaginous thickness. So the cartilage is basically getting degraded. The cartilage loss is focal. First of all, it is local and it is restricted to the maximum load bearing area of the joint. So whatever cartilaginous changes are taking place, it is local and it is totally based on the maximum load bearing point. These changes in the cartilage encourages deposition of calcium pyrophosphate and basic calcium phosphate crystals, CPPD crystals. So the changes encourages the deposition of calcium pyrophosphate and basic calcium phosphate crystals. So this can eventually lead to the development of the crystal deposition diseases like gout. Now these are the changes. First of all, we have the cartilage and the bone, and there is thinning of the cartilage. This is the pathophysiology basically that is occurring in case of osteoarthritis. So we have the cartilage, then there is thinning of the cartilage, and ultimately the cartilage is totally depleted and the bone is rubbing against the surface. Now there are a lot of bony changes that are occurring in the body. The subchondral bone shows the mixture of osteolysis and osteosclerosis. There is subchondral cyst that develops as a result of small area of osteosclerosis. So we have subchondral bone that shows the mixture of osteolysis and osteosclerosis. There is subchondral crystals develop as a result of small areas of osteonecrosis. So there is necrosis of the bone. The new fibrocartilage at the joint margin undergoes endochondral ossification from the osteophytes. There is severe cartilage loss leads to the attraction of bone. The wear ablate the trabeculae and lead to the smooth, shiny surface with deep linear grooves. There is bone remodeling and cartilage thinning that slowly alters the shape of the osteoarthritis joint, increasing the surface area. So there is bone remodeling and cartilage thinning that slowly alters the shape of the osteoarthritis joint, increasing the surface area. Now this is also again the pathophysiology. First of all, the healthy joint. Next is the mild osteoarthritis changes, and the third is with the severe osteoarthritis. In case of severe osteoarthritis, you can see the cartilage loss and the bone remodeling. On the right side, you can see a normal joint with the muscles, the bursa, synovial membrane, the bone, the tendon, cartilage, joint capsule, and the synovial fluid. Whereas in case of osteoarthritis, we have eroded cartilages, we have bone ends that run together. There is fusion of the bones and the bones rub against each other, leading to the deterioration of the bone. Now we come to the other changes in case of the cartilage. We had a cartilaginous change, joint change, and other changes. So the synovium that undergoes variable degree of hyperplasia. There is a variable degree of hyperplasia in the synovium. You can see the osteochondral bodies that occurs within the synovium, reflecting chondroid metaplasia or the secondary uptake and growth of damaged cartilage fragments. The outer capsule thickens and contracts, retaining the stability of the remodeling joint. So the stability of the remodeling joint is maintained. The muscles acting over the joints show non-specific type 2 fiber atrophy. So the muscles that are acting over the joints shows a non-specific type 2 fiber atrophy. Now we come to the clinical features of osteoarthritis. Whenever a patient of osteoarthritis is coming to us, what are the clinical features with which the patient can present to us? The complaints of osteoarthritis usually starts over the age of 40 years, often greater than 60 years. The onset is insidious, that is slow insidious onset over the months or years. Only one or few of the joints are painful in the beginning. So the onset is usually insidious, slowly developing over the months or years, and it affects one or few painful joints in the beginning. The main presenting symptoms are pain and functional restrictions. So the main thing is pain and functional restriction. The joint pain from osteoarthritis is activity related. So the joint pain is basically activity related. The pain comes either during just first after the joint use and then gradually resolves. So the first pain that occurs in osteoarthritis is usually on beginning to move, and then with the motion, the pain is usually relieved. So the main presenting feature is the pain and functional restriction, and the pain comes either during the first or just after the joint use and then gradually resolves. So once the patient starts to move, the pain first of all increases and then the pain reduces gradually. Now the example includes the knee and the hip pain with going up and downstairs. So whenever you are going upstairs or downstairs, the pain is there. The pain in the weight bearing joints when walking, when the patient is walking, and in the weight bearing joints we have the pain. And for hand osteoarthritis, pain when cooking. So whenever a patient is cooking, the patient is having osteoarthritis pain. The pain is mainly related to the movement. That is, whenever the patient is moving, the pain is there, and the weight bearing, and it is relieved by rest. So the pain is worse by movement and is better by rest. The joints commonly involved are knee joint, hip joint, spine, and hands. So we have knee joint, hip joint, spine, and hands. The hands distal interphalangeal joints, that is DIP joints, proximal interphalangeal joints, and first carpometacarpal joints are usually involved. So we have the knee joint, the hip joints, and the hands, and there are distal interphalangeal joints, proximal interphalangeal joints, or first carpometacarpal thumb base that is usually involved. Initially, the pain is worse after overactivity. So whenever the patient is doing overactivity, the pain is worse of the affected joint, and the pain is better by rest. Later on, the pain becomes continuous. So as the disease progresses, the pain becomes continuous and is worse at nights. There is stiffness of the affected joints that is prominent, but morning stiffness is usually brief, that is less than 30 minutes. So stiffness is prominent, but morning stiffness is usually brief, that is less than 30 minutes. The clinical signs involves the restricted movements of the joints due to the capsular thickening, blocking of the by the osteophytes. You can also find the joint crepitation, that is crackling due to the rough articular surfaces. So you can also find crepitations in case of osteoarthritis. There will be bony swelling, that is osteophytes around the joint margins. There will be joint deformity, and it is usually without instability. The joint line or the periarticular tenderness will be there. There will be muscle weakness and wasting of the muscles. There will be no or only mild synovitis that is present. Next, we have another important topic, that is nodal generalized osteoarthritis. Nodal generalized osteoarthritis is seen typically in the middle-aged women between 40 and 50 years of age who develop pain, stiffness, and swelling. Those who are developing pain, stiffness, and swelling, that is seen in those cases, and one of the few finger interphalangeal joints, IPJs. Gradually over the months, more fingers interphalangeal joints, that is distal is more than case of proximal, are affected. The posterolateral swelling on each side of the extensor tendon slowly enlarges and hardens to become Haberden's nodes. Haberden node is seen in case of distal interphalangeal joints, and Bouchard nodes that are seen in case of proximal interphalangeal joints. So we have two types of nodes that are prominent in case of osteoarthritis. We have Haberden's nodes, that is distal interphalangeal joint involvement, and Bouchard's node, that is proximal interphalangeal joints involvement. You can see the Bouchard node and the Haberden's nodes. Now, the affected interphalangeal joints often shows the characteristic lateral deviation. As you have seen in the previous picture, there was lateral deviation that was reflecting the asymmetric focal cartilage loss. There is involvement of the first carpometacarpal joint, that is also common. There is marked osteophyte and subluxation that may result in thumb-based squaring of the first carpometacarpal joint. People with a nodal osteoarthritis are at increased risk of osteoarthritis at the other sites. It is also having a very strong genetic predisposition. Now you can see in this case the Bouchard node, that is proximal interphalangeal joints, and the Haberden's nodes, that is distal interphalangeal joints, and squared off base of the thumb. And you can also see in the knee joint the malalignment, the swelling, and the crepitations. In the knee osteoarthritis, it targets the patellofemoral and medial tibiofemoral compartments of the knee joint. It is common in women and often bilaterally symmetrical. The trauma is the most common cause of knee osteoarthritis. The pain is worse in going up and down stairs or inclination. The local examination of the knee joint reveals a jerky, asymmetric, that is antalgic gait. A varus, that is less commonly valgus, or a fixed flexion deformity is seen. Next, we have deformities in the knee osteoarthritis. As the opposing cartilage surfaces wear away, the knee collapses, causing deformities such as bow-leggedness, that is genu varus, and knock knee, that is genu valgus. There is weakness and wasting of the quadriceps muscles. The restricted flexion or extension of the cors crepitus. There is bony swelling around the joint line. Apart from this, there is deposition of the calcium pyrophosphate dihydrate, that is CPPD crystals, in association with the osteoarthritis, is most common in knee joint. The deposition of the CPPD crystals results in more overt inflammatory components that is characterized by stiffness and effusion, and superadded acute attacks of synovitis, that is known as the pseudo gout. Next, we come to the hip osteoarthritis. When the hip joint is involved in case of osteoarthritis, it is the most common targets the superior aspect of the joint. Such superior pole osteoarthritis is often unilateral in presentation and often progresses as superolateral migration of the femoral head and has a poor prognosis. The less common is central, that is medial osteoarthritis. It shows more central cartilage loss and largely confined to the woman, often bilateral in position. The hip shows better correlation between the symptoms and the radiographic evidences. Hip pain is usually maximum deep in the anterior groin with variable radiation to the buttocks, anterolateral thighs, knees, or shin. Lateral hip pain worse on lying on that side with tenderness over the greater trochanter. This suggests secondary trochanteric bursa. The restricted hip abduction in women may cause pain after intercourse. Now, the examination of hip osteoarthritis reveals the antalgic gait, the weakness and wasting of the quadriceps and gluteal muscles. There is pain and restriction of the internal rotation of the hip when flexed. Anterior groin tenderness just lateral to the femoral pulse. There is fixed flexion, external rotation deformity of the hip joint, and there is ipsilateral leg shortening with severe joint attrition. In early onset osteoarthritis, there is typical symptoms and signs of osteoarthritis may be present before the age of 45 years. A single joint is affected and there is clear history of previous trauma. In early onset osteoarthritis, multiple joints are not involved. Commonly affected are patients with endemic osteoarthritis due to the unknown environmental cartilaginous toxins. Next, we have erosive osteoarthritis. This is another type of osteoarthritis that is a rare disease. So, you don't find erosive arthritis so commonly. The patients with interphalangeal joints osteoarthritis who have a more prolonged symptom phase, more overt interphalangeal inflammation, more disability and worse outcome than those with a nodal osteoarthritis. Distinguishing feature from the nodal osteoarthritis includes preferential targeting of the proximal interphalangeal joints, common development of the interphalangeal lateral instability, subchondral erosion on the X-rays. We have occasional eventual ankylosis of the interphalangeals joints and lack of association with osteoarthritis elsewhere. What are the physical examinations in case of osteoarthritis? In osteoarthritis, we have chronic monoarthritis or asymmetrical oligo or polyarthritis. So we have monoarthritis, either single joint is involved, or asymmetrical involvement of the few joints or multiple joints. Bony swelling of the joint margins, example Haberden's nodes and Bouchard nodes are seen. We have Bouchard node and Haberden's node that I have already discussed previously. There is mild synovitis with a cool effusion. There is crepitance, audible creaking or crackling of the joints on passive or active movement. There is deformity, example osteoarthritis of the knee may result in valgus or varus deformities. The reaction of movement, example limitation of internal rotation of the hip. In case of investigation, no blood tests are routinely indicated for the workup of the patients with osteoarthritis unless the symptoms and signs suggest of inflammatory arthritis. The examination of the synovial fluid is often more helpful diagnostically than an X-ray. The joint fluid is straw-colored with a good viscosity. Fluid WBC less than 1000 micro per microliter of value in ruling out the crystal-induced arthritis, inflammatory arthritis or infection. The full blood count ESR and CRP are usually normal in case of osteoarthritis. The CPPD crystals and basic calcium pyrophosphate are also being identified. The radiographs may be normal at first, but as the disease progresses, may show joint spaces narrowing, subchondral bone sclerosis, subchondral cyst, and osteophytes. The plain X-ray may show one or more of the typical features of osteoarthritis. PA view of the pelvis is adequate for assessing the hip osteoarthritis. Standing stressed AP radiographs are needed to assess tibiofemoral cartilage loss. Flexed skyline view is best for assessing patellofemoral narrowing. Although MRI may reveal the extent of pathology in an osteoarthritic joint, it is not indicated as a part of diagnostic workup. The radioisotope bone scans performed for other reasons often show an incidental finding. Now this is the radiograph X-ray of the knee joint with medial osteoarthritis. Note the narrowed joint spaces on the medial side of the joint only, white arrow. The sclerosis of the bone in the medial compartment provided evidence of cortical thickening, that is black arrow, and osteophytes in the medial femur, that is white wedge. Next we have diagnosis of the osteoarthritis. Diagnosis is usually established on the basis of pattern of joint involvement. Whichever joint is involved, the diagnosis is done accordingly. The radiographic features, the normal lab investigations, and synovial fluid finding. So on the basis of pattern of joint involvement, radiographic features, normal lab test, and synovial fluid finding, we are diagnosing the case of osteoarthritis. Now, what are the differential diagnoses in case of osteoarthritis? Number one, we have inflammatory arthritis. Is if there is prolonged morning stiffness and many joints are affected, then we can think of inflammatory arthritis. The bursitis occurs commonly around the hip joint and the knee joint. There is anserine bursitis. Medial and distal to the knee is an extreme common cause of knee pain that may respond to the glucocorticoid injection. The pain isolated to an area lateral to the hip joint usually reflects the presence of trochanteric bursitis. The synovial fluid white count is greater than 1000 per microliter. Inflammatory arthritis or gout or pseudogout is likely. Now, what is the treatment for osteoarthritis? The treatment goal is to alleviate pain and minimize the loss of physical function of the joint. We have non-pharmacological therapies useful for osteoarthritis. The full explanation of the condition, weight reduction, appropriate use of cane and other supports are useful. We have isometric exercises to strengthen the muscles and around the affected joint. We have correlation of the malalignment frontal plane, that is varus valgus, surgically or with the bracing. We have tropical capsaicin cream may help to relieve the hand or the knee pain. Next, we have acetaminophen, that is commonly used as analgesics. We have NSAIDs, COX-2 inhibitors, opioid analgesics, which have the symptoms inadequately controlled or those who cannot undergo surgery. We have intra-articular glucocorticoids with a symptomatic relief but short-lived. Next, we have intra-articular hyaluron that can be given. The surgical management of case of osteoarthritis includes the joint replacement surgery in patients with pain, stiffness, and reduced function impact significantly on the quality of the life and are refractory to the non-surgical core and adjunctive treatment. The knee joint has arthroscopic debridement and lavage. Next, we have arthroscopic meniscectomy is for acute meniscal tears. We have high tibial osteotomy. Next, we have total knee or hip arthroplasty with a knee or hip replacement. Homeopathic management of osteoarthritis, although the constitutional treatment is advised in the patients with osteoarthritis, but there are certain specific medicines which offers instant relief in the painful conditions of stiffness, limitations of movement. We have arnica, that is given after the traumatic injuries with a soreness after overexertion, pain in the back of the limbs as if bruised or beaten. We have bryonia that acts on all serous membrane. The pain is a stitching, tearing, worse by motion and is better by rest. We have causticum that is given in case of chronic rheumatic, arthritic, paralytic affections with a tearing, drawing pains with deformities about the joints, progressive loss of muscle strength. Next, we have the colchicum. It affects the synovial membrane of the joint stiff and feverish with shifting rheumatism. Pain is worse at night, knees strike together, and the patient can hardly walk. Next is the ledum pal with a rheumatism that begins in the lower limbs and usually ascends. Next, we have McCabe. McCabe has the tearing in the shoulders as if dislocated. Right shoulder pain cannot be raised. Next important medicine is McFoss, which has the neuralgic pain that is better by warmth. Nux vomica, we have crackling in the knee joints during motion, drags his feet when walking. There is sensation of sudden loss of power of the arms and legs in the morning. Next, we have pulsatilla, where the hip joint is painful, the knees are swollen with tearing, the drawing pains, boring pains in the heels towards the evening. Next, we have rustox, where the pains and stiffness of the joint, pains are tearing in tendons, ligament and fasciae. The pain is worse in the wet rainy weather and after rain, at night and during rest, and the pain is better by motion. Next, we have rhododendron, the rheumatic tearing pain in all the limbs, especially on the right side, worse at rest and in the stormy weather. There is stiffness of the neck, pain in the shoulders, arms, wrist, they are worse at rest. Next, we have sulfur. Sulfur contains the stiffness of the knees and ankles. The patient cannot walk erect. He walked stoop shoulders, rheumatic pain in the left shoulder. So this was all about the management of osteoarthritis. So in today's lecture, we have discussed about osteoarthritis in detail. We have discussed about the pathology, the pathophysiology, the clinical features, the investigation, the management, everything about osteoarthritis. So this was all about osteoarthritis. In the next lecture, we are going to discuss about rheumatoid arthritis. This lecture was powered by Digital Version 2.0 Jayoti Vidyapeeth Women's University. I hope you are satisfied with my digital session. If you have any issue, kindly write in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow. Thank you. Namaste.